So let's talk about stroke secondary prevention and management. I also have many slides, so we'll see how we do with the time, and I may have to go through some slides fast, but we'll have some time for question and answers. First, I wanted to create this lecture with AI, and I thought like AI will create all the slides for me, but they um, it gave me some pro forma and very basic information, so I did not use that. But I asked AI to create a funny cartoon doctor treating a stroke patient, and this is what I got on ChatGPT. Um, so So why it is important, we talk about stroke prevention and beyond acute phase. Dr. Deshmukh mentioned about acute treatment with mechanical thrombectomy. So 15 to 20% patients, they have large vessel occlusion. They can be treated with acute mechanical thrombectomy up to 24 hours if they have a large vessel occlusion. But 80% patients, they have not large vessel occlusion, and then we need to take care of them. We need to figure out what is the stroke mechanism and how we can prevent the recurrent stroke. So current stroke incidence rate in United States is around 800,000 patients. Mostly 85% of them or 87% of them are ischemic stroke. Important thing is almost 20% of them are recurrent strokes. So we have done better compared to 50 years ago. So recurrent stroke risk has come down, but still recurrent stroke is a big issue. So I think we have to think through thorough workup and how we can prevent the second stroke. As we all know that 80% of cardiovascular disease, stroke and heart attack, they are preventable with modifiable risk factors. So we'll talk about those things too in brief. Um, as a stroke neurologist, when I see the stroke patients in my clinic or even in acute phase, I think the first thing beyond acute treatment options like IV thrombolytics in first 4.5 hours or thrombectomy, next day our goal would be what is the stroke etiology. So taking care of them is important thing, but also we start thinking about what is the stroke etiology. And the most common etiologies are large vessel disease, either extracranially in carotid artery or intracranially in one of the major blood vessels, small vessel disease, cardioembolic stroke, other causes like coagulopathy or arterial dissection, and even after all the workup, still so many strokes are what we call, we don't find the reason, cryptogenic stroke. And then I'll go through some of these causes, the important causes, and what we do for the workup and how we can prevent those things. We'll go through some case studies, we'll review pathophysiology, we'll talk about some guidelines and practice considerations. Um, so American Heart Association, they came up with stroke prevention guideline. We are talking about secondary stroke prevention. I know that most recently they also came up with primary um, stroke prevention guidelines, but here we are talking about guidelines after the stroke happens. So, and then in this guideline, there is a level of recommendation. So usually class 1 or class 2 a recommendation, they are stroke recommendation, they are strong recommendation. Those patients should be treated with those recommendations. 2B is weak recommendation, but still can be considered. Usually class 3 recommendation are not considered or they are harmful. So we'll talk about that in different scenarios. So let's start with small vessel disease, stroke, and TIA. Again, another cartoon here. I asked AI to create turtle with small vessel disease, and this is what I got. Um, so first patient, 69-year-old with uncontrolled risk factors, hypertension, diabetes, and hyperlipidemia. And the presentation was fluctuating right-sided weakness for a day with very high blood pressure. Stroke scale was 2. We use NI stroke scale in acute settings. So in this setting, we can think about what is it's going to be stroke. We know that what kind of stroke it would be, whether it is going to be small vessel disease, cardioembolic, intracranial atherosclerosis, arterial dissection. It can be any of that, but I have to think about along with the risk factors, and you can all guess it's going to be small vessel disease. Could also be intracranial atherosclerosis or carotid artery disease. So this patient had CT angiogram. There was no large vessel occlusion or significant stenosis in any arteries. EKG or inpatient telemetry did not show any atrial fibrillation. Typically, patients with small vessel disease, they do not require extended telemetry, and in some cases, they also don't require echocardiogram. This patient was treated with dual antiplatelet with aspirin and Plavix for 21 days, along with high intensity statin. So let's talk about lacunar stroke. A small vessel disease stroke, they typically happen in the subcortical region. So the most common region when this stroke happens are basal ganglia, internal, what is basal ganglia, internal capsule, in the midbrain, sometimes in the cerebellum. And we'll talk about why. So these are the arterioles. These are lenticulostriate branches of the middle cerebral artery where the blood pressure fluctuation is highest. So in patients with uncontrolled hypertension or patients with other risk factors, endothelial dysfunction can happen at the arterial level, and they can develop arteriosclerosis or atherosclerosis, small vessel plaques, or small vessel can rupture also. So that's how they get microbleeds. But these are the common places where we get small vessel disease stroke. So what are the class 1 recommendation for treatment of this? As we know that the main treatment for these patients are antiplatelet medication. Now, single antiplatelet agent is the standard of care aspirin, clopidogrel, or aspirin and dipyridamole combination. When do we use dual antiplatelet therapy in these patients? When patients present to hospital with either high-risk TIA or if they have minor ischemic stroke. Usually our definition of minor ischemic stroke when their stroke scale is less than 5. We call them minor ischemic stroke. And then when we do MRI and if the stroke volume is very small and they look like small vessel disease stroke, usually we give them dual antiplatelet therapy when they are within 24 hours because recurrent stroke risk is highest in first week. So those patients, we treat them with aspirin and Plavix for 21 days, and there are certain reasons where we extend it up to 90 days. Um, Class 2B recommendation, one recent trial, health trial, also gave beneficial effect of aspirin and ticagrelor combination for 30 days. So some patients we also treat with that, but mostly our current practice is aspirin and Plavix if they present within first 24 hours. If they present after 2-3 days with fluctuation of symptoms and we know that it's a small vessel disease, usually we don't start dual antiplatelet unless we find significant intracranial or extracranial atherosclerotic process. Um, and usually aspirin 81 milligram or 325 milligram. I think in cardiac literature, there are some recommendation about increasing dose and better effect, but in stroke world, we don't have those kind of randomized trials showing beneficial effect of increasing dose. Sometimes we do that when we don't have option, but we don't have good data supporting that practice. And class 3 recommendation, dual antiplatelet therapy beyond 90 days can be harmful, increases the bleeding side effect. And then dual antiplatelet therapy with anticoagulation, there is no data to support that. On case by case basis, sometimes we do that, and I would tell you those scenarios. Um, so in practice consideration, single versus dual antiplatelet therapy, I mentioned that when we see patients in first 24 hours, we always consider dual antiplatelet therapy. Usually we start with the clopidogrel load 300 milligram on day 1, followed by 75 milligram of clopidogrel for 21 to 30 days, along with the aspirin low to medium dose. And we continue up to 30 days. For small vessel disease prevention, American Heart Stroke Association also promoting now this Life's Essential 8, and we are seeing more and more data that is coming up with the lipid management with diet actually. So in these cases, in so many cases, we see inflammation in the blood vessels with the plaque. So it's very important that beyond just the medication management, we also talk about this, and you all are at the forefront of managing all these risk factors. So it's very important. We talk about weight management, we talk about diet, smoking cessation, healthy lifestyle, healthy sleep, along with the control of blood sugar, cholesterol, and blood pressure. In this graphic, you can see that at any age group, if the blood pressure is above 160 or above 180, whether it is men or women in any age group, the risk of cardiovascular event is significantly high compared to the patient who have normal blood pressure. Usually with the blood pressure management for stroke prevention, the primary line of management is thiazide diuretic angiotensin converting enzyme inhibitor or ARB inhibitors. And the blood pressure goal should be less than 130/80. So one thing I want to emphasize here is permissive hypertension. We allow permissive hypertension in small vessel disease up to 2 to 3 days. But our goal is to start maybe even low dose blood pressure medication if they are stable for 24 to 48 hours. Sometimes we start it in the hospital, and when they follow up with the primary care then we should further take the action to bring it down to 130/80. So we don't want to keep significant high blood pressure for so many days as long as clinically patient is very stable. There are certain exceptions. Very old age patient, we know that sometimes they can have side effect from medication, and you don't want to push it down significantly. And in those cases, we can go for 140/90. But and then if there is intracranial atherosclerosis, very high grade stenosis, and we feel that in initial phase patient had significant hypoperfusion or fluctuation, in those cases, sometimes we allow permissive hypertension for a few more days. But otherwise, our goal is to keep it less than 130/80 for long-term blood pressure goal. Regarding hyperlipidemia, there are trial and data supporting high-dose statin use, Crestor 40 milligram or atorvastatin 80 milligram daily. And the goal of the LDL is less than 70. Cardiology literature is moving towards LDL goal less than 55 for patient with coronary artery disease. There are more options for treatment. I think this is one of the part in vascular neurology. As a even stroke neurologist, we feel that we need to improve discussion about this with the patients. When we see that, I think we all start patients on high dose statin. But regarding follow up, or if they are not adherent, or if they have any side effects, I think we are not very forceful compared to the cardiac patients in bringing down the LDL. But data is supportive of that. So there are more options. PCSK9 inhibitor should also be thought about in patients with significant atherosclerotic process intracranially or extracranially. So there is enough data to support that patient with either small vessel disease or large vessel disease, when they have atherosclerotic process going on, then patients should be started on high dose statin. Even if you don't see significant plaque buildup, but if they have microvascular disease in the brain or brain MRI, we read that report on all CAT scan, all MRI, chronic microvascular disease. Those patients can get benefit from for secondary stroke prevention with high dose statin. Let's move on to large artery atherosclerosis. Again, this is what I got from AI for extracranial atherosclerotic process and the stroke. Just going over the basic anatomy to give you idea. Let's see, okay, my arrow shows up there. So this is the common carotid artery bilaterally. Behind there is a vertebral artery. Still we are in the neck. At this point, it is the intracranial portion. So internal carotid artery in the brain divides into middle cerebral artery, anterior cerebral artery. This is the basilar artery. Combination of two vertebral artery becomes basilar, then it becomes posterior cerebral artery on the both sides. So this is the circle of Willis, what we call. It's important to know this anatomy, and for when we talk about disease etiology and try to find the stroke reason, the knowing the anatomy is very important for us. So let's talk about the case. So this was the 77-year-old woman with hypertension and hyperlipidemia. She presented with 2 episodes of right hand weakness and slurred speech. Both lasted just for 15 minutes. When she presented, her stroke scale was 0. She got CT scan and CT angiogram in the ER. And then this is what we found. Left eye CS stenosis with mixed density plaque here, 85% narrowing according to NASET criteria. Her MRI showed a very, very small stroke in the left frontal lobe. And that's why I think she did not have any residual symptoms. So she underwent carotid endarterectomy. So for intracranial or extracranial diseases, it's very important to understand the location, the degree of stenosis, and how the plaque looks. So here we can see there are plaque in the left vertebral artery. This is intracranial stenosis. This is extracranial stenosis in the left internal carotid artery. Most common location for formation of atherosclerotic plaque is carotid artery, then intracranial carotid artery. also junction of the vertebrobasilar artery and also top of the basilar. So these are the common location where we see atherosclerotic process in patients with stroke. Um, Usually up to 50%, up to 70% narrowing in the carotid artery flow still remains good. When narrowing becomes more than 70%, we start seeing the decrease in flow and we start seeing some hypoperfusion effect. We start seeing high risk of thromboembolic plaque and thromboembolism in those patients. So this is the appearance of plaque, and the reason that this is very important, when we see the patient with CT in the hospital, we look at the CT angiogram, we look at the MR angiogram. There are calcified stable plaque and there are irregular plaque which are highly vulnerable for further rupture or further thromboembolism. So if there is a necrotic base, if there is ulcer in the plaque, if they have a mural thrombus or thin fibrous cap, so these are the patients who can have high risk of thromboembolism. So even in some cases when their degree of stenosis is not more than 70%, or we let's say that we find this kind of plaque and their stenosis is 50 to 69%, still we recommend going for carotid revascularization procedure. So the most important things we think about when we see patient with the carotid atherosclerosis is the patient symptomatic from carotid stenosis? What is the degree of stenosis and how soon we need to do carotid revascularization? So it depends. What is the definition of symptomatic carotid stenosis? So the definition is if anyone has any event in 6 months prior to finding carotid stenosis, if there is any TIE or small stroke from that lesion, then we technically define that as a symptomatic carotid stenosis. So in this data, you can see that when there is a narrowing between 70 to 99%, there is significant benefit going for carotid revascularization procedure, CEA compared to the control arm. And this was all like published in 1990s with the NASET trial. And this is the main trial which inform our decision about how we should be aggressive in treating carotid artery stenosis beyond 70%. But there is benefit between 50 to 69%. So there are subset of patients where we refer them to vascular neurosurgeon for fixing the carotid artery when the narrowing is more than 50%, and we feel that that is still a symptomatic lesion. Then we send them to specialists for further options, treatment options. So the treatment options are either carotid artery stenting or carotid endarterectomy. Both are very effective. Nowadays, there is another procedure that vascular surgeons do. It's called TCAR, transcarotid artery revascularization. It's a minimally invasive procedure where they put a stent through the small incision in the neck. And stroke risk is lower with that procedure. It's a less invasive, shorter length of stay, less risk of heart attack or nerve damage. Um, Carotid endarterectomy is the main treatment option, but in 2010, with the publication of trial CREST, now we know that the carotid artery stenting is also equally effective. So now both options are available to the patients, and then um, neurosurgeon or vascular surgeon can choose according to patient anatomy and age which option would be better. I know that in older age patients, when it is straightforward anatomy, they choose carotid endarterectomy when there are no other significant risk factors or comorbidities. But there are subset of patients which can benefit from carotid artery stenting and also TCAR procedure. So carotid revascularization is a standard of care class 1A recommendation for patient with narrowing of 70 to 99%. While they are awaiting for the procedure, usually we put them on antiplatelet therapy. In certain patients, when we know that they are going to go for stenting, then we put them on dual antiplatelet therapy even before going for the procedure. Usually we recommend, if we find that there is a degree of narrowing more than 70%, we see this patient in the hospital, or let's say in the outpatient setting, you come to know and small TIE or small stroke has happened. The current recommendation is they should be treated as soon as possible within first 2 weeks. So in most cases, when we feel that the stroke is small and we can fix this lesion while they are hospitalized, we try to do that. If they have a moderate to large size stroke, then we have to wait for a few more days. And we have to see that how much benefit we get from the carotid revascularization procedure. Um, So let's talk about symptomatic extracranial vertebral artery stenosis or basilar artery stenosis. So usually in those patients, The primary recommendation would be to put patient on antiplatelet therapy, treating their cholesterol, treating their blood pressure, and then advising about the modifiable risk factors. Stenting is not indicated as a first line of management in intracranial stenosis or in patients with extracranial vertebral artery stenosis. And we'll talk about a bit more in next slides. So let's talk about intracranial atherosclerotic disease. 76-year-old women with type 2 diabetes, remote tobacco use history, hypertension, and hyperlipidemia. She presented with profuse bleeding from varicose vein after injury in bathtub and found to have slumped in chair with left gaze deviation, aphasia, and flaccid right side. She got some IV fluid bolus, did not get thrombolysis with bleeding history, turned out to be having a severe left MCA stenosis. So here you can see left MCA, very, very high grade stenosis. So in this patient, the current guideline supports the management with dual antiplatelet therapy. Um, so this is another case. When you do MRI, uh, this patient had a small stroke in the left frontal lobe. So it is in the border zone, ACA and MCA border zone. Usually management would be permissive hypertension. Initially, you support them with the IV fluids and then give them antiplatelet therapy for 90 days along with the high dose statin. So the same thing like extracranial carotid artery disease, we have to think about whether it is symptomatic lesion or not, what is the degree of stenosis, whether it is responsible for the mechanism of stroke or not. So when we see patient with intracranial atherosclerotic disease, the usual mechanisms are these four. Either they can have a thrombotic occlusion, acute on chronic occlusion. They could have artery to artery embolus. They can have branch blockage from that high grade stenosis, or they could have hypoperfusion injury to the brain. This is the depiction of when they would have perforator occlusion. So if there is a high-grade stenosis and the small blood vessels coming out of that high-grade stenosis, they can have a blockage and they could have a stroke. This is we are seeing like basilar artery stenosis, and then this is the perforator to the pons, and then it can be blocked and they can develop diseases. So even though it looks like small vessel disease, it could be due to high-grade basilar artery stenosis. So what is the data that we have that this patient should be treated with dual antiplatelet therapy compared to and not with the stenting as a first line of management? So in 2008-9, when endovascular world was in initial phase, particularly for treatment of acute stroke and stenting, there was a stent, wingspan stent, that came out, and then there was lots of excitement that it would move towards just like cardiology, where stenting would become the main line of treatment for certain cases. So they did this trial, Sampris trial, where they found the patient with high-grade intracranial symptomatic stenosis, mainly MCA stenosis. If they were more than 50 or 70% stenosis, they put patient on aggressive medical management arm compared to stenting arm. And they did not find significant benefit. So actually, stroke risk in first month was much higher in the stenting arm. It was 14% compared to the dual antiplatelet therapy and statin. It was only 6%. So that decreased the enthusiasm of going for stenting on all patients with intracranial atherosclerotic disease. So the current guideline is treat them with the dual antiplatelet therapy when we find more than 70% stenosis in MC or intracranial basilar artery or vertebral artery. We treat them with aspirin and clopidogrel for 90 days. So these are the cases we treat them up to 90 days. I've done it up to 6 months in some patients. When we go beyond that, we don't have literature to support that. So there are patients when they have a recurrent event, we sometimes go beyond that. And that is when we send patient to Dr. Deshmukh and his team for further opinion options. And then he does cerebral angiogram. So this is one example where left vertebral artery, you can see high-grade stenosis. Patient had recurrent posterior circulation symptoms. Patient on maximum medical management with aspirin and clopidogrel was still symptomatic. And after initial trial of 90 days treatment, if we feel that patient is still symptomatic, these are the patients you can make exception and send them for neuroendovascular treatment. And this patient got a stent. So that would be the management for intracranial atherosclerotic disease. Let's move on to cardioembolic stroke. So this is again another cartoon I got from AI regarding the cardioembolic stroke. Let's talk about the case. Yeah. So this was 65-year-old women with hypertension, no other risk factors. She presented with 2 to 3 hours of expressive aphasia, which resolved. And on MRI, she had a small stroke in the left MCA territory. So this location, we call it cortical location. So when we see the MRI, we always think about it is a cortical or subcortical because that informs us our decision making, whether it is from the large vessel disease or from cardioembolic source, or it is from small vessel disease. So on vessel imaging, patient did not have any significant atherosclerotic process. Echocardiogram was normal. This is another case. 55-year-old man with sleep apnea, possible sleep apnea, hyperlipidemia, and then 1 day history of word finding difficulty, very mild. Stroke scale was only 1, and MRI showed scattered MCA territory infarct. Again, CT angiogram was normal, echocardiogram was normal. So in both cases, when we see this kind of MRI with normal blood vessels, we don't have a good reason to think like, okay, why stroke happened? It is in the cortical location. It's not a small vessel disease. So we have to think about cardiology as, heart as main issue here. So when we think about the cardiac sources, arrhythmia is the most common reason. Atrial fibrillation, atrial flutter, sometimes structural abnormality, sometimes significant heart failure or LV dysfunction, or in rare cases, patients with drug use or patient with other valvular history, they can have infective endocarditis. So we think about those things when we see this kind of MRI. So our usual workup in inpatient side, we do transthoracic echocardiogram with bubble study. We can also do TCD, transcranial Doppler, to look for the PFO. So we can do that. In some cases, if we feel like, okay, we need to look at the heart more and more thoroughly, then we can go for TEE or cardiac CT scan or cardiac MRIs. Outpatient workup, let's say the in inpatient side, we don't find any atrial fibrillation while they are in the hospital for 2 3 days on telemetry. We send them out with extended cardiac telemetry for 2 to 4 weeks. And in rare cases on outpatient side, we also send patient to cardiologist for implantable loop monitoring device. So in both cases, I don't think so that we found atrial fibrillation while patients were hospitalized. So even though we were thinking that this is a cardioembolic stroke, do we have enough data to support that this patient should be started on anticoagulation? No, we don't. So this patient would be started on antiplatelet therapy plus statin. Patients, they were discharged on Holter monitoring. And on the case number 1, we found atrial fibrillation, 8% burden of atrial fibrillation, and longest was 5 hours. So this patient was started on anticoagulation with DOAC. The second patient, we did not find AFib on 4 weeks of cardiac monitoring. So we call it ESIS, that is embolic stroke of unknown source. And in that patient, we still don't have enough data to support the use of anticoagulation. So these are the patients, sometimes we go for further implantable loop monitoring device. So we refer them to cardiologists, and in some cases I've seen that our practice is to do that first. In some hospital, in some settings, I've seen that patients get implantable loop monitoring device while they are hospitalized. So both practice are fine, but I think you have to think beyond those 2 to 4 weeks. If you feel like there is a high probability of this being a cardioembolic stroke, then you have to keep looking for the source. You have to keep looking for atrial flutter fibrillation. So this is one of the score. We don't use it all the time, but it is a good resource, AF ESIS score. And then it takes into account the different risk factors. We feel that, so score of 0 or less, the likelihood of the stroke or finding AFib is very low on implantable loop monitoring device. But when score is more than 0, then the likelihood of finding atrial fibrillation on follow-up is pretty high. So, the mainly, if you see that there are some -1, -3, a -2 or -3 score, and then that just gives you the other etiology for cardioembolic stroke. If they have cardiac failure or EF is low, or if they have any carotid plaque buildup or subcortical infarct, you are bringing that score to the negative side. So in those cases, this being from AFib is somewhat less, and you're not going to find AFib on those patients. But when the pretest probability is high, when we think that it is a cardioembolic stroke, we go for implantable loop monitoring device. So we sometimes go beyond 4 weeks for those things. So current guideline supports the oral anticoagulation. We have different options along with warfarin. DOAC is preferred over warfarin according to current guidelines. And we have to remember these are non-valvular atrial fibrillation or TIA. There is more data. I think I would inform. I would talk about that. We used to wait for 2 weeks after for starting anticoagulation in patients with stroke. Now there are two big trials came out showing the effectiveness of starting an anticoagulation early after the stroke. So in hospital setting, when we do MRI or we know that this patient has cardioembolic stroke, sometimes we have to wait for starting anticoagulation. But how long do we wait? So the examples that I showed you, MRI showed very, very small stroke. I would not wait for 2 weeks on those patients. I would start anticoagulation either next day or in 2 to 3 days. If it is a very large stroke, then still I think we have to wait for 10 to 14 days, or if there is a small hemorrhagic conversion, we have to wait for 10 to 14 days. Sometimes we repeat CAT scan before we start anticoagulation. But there is more data to support early use of anticoagulation, and recurrence of stroke on those patients is less compared to you wait for 2 full weeks. So now we don't wait that long. Let's talk about the options when patient can't go on anticoagulation. When they can't go on anticoagulation, there is a device, Watchman device. We do that procedure, and I think many systems across Oregon, they do this procedure. Most of the cardioembolic stroke, this clot burden is in the left atrial appendage. So patients with possibility of amyloid angiopathy, like a small microbleeds in the brain, or if they have other bleeding side effects where they can't go on anticoagulation, we send patient to the cardiologist for this procedure for the Watchman device. And there is enough data to support that. It's a class 2B recommendation, can be considered. And it's kind of standard of practice right now for certain patients. Um, this was a 54-year-old female, 54-year-old patient without any vascular risk factor. Patient presented with left-sided weakness, neglect, and homonymous hemianopsia. CT angiogram showed right M1 occlusion. Patient received IV thrombolysis. And then patient had some clot migration, so there was some distal migration. MRI showed scattered right MCA territory infarct, and inpatient telemetry while patient was in the hospital for 3-4 days did not show any atrial fibrillation. But transthoracic echocardiogram with bubble study showed right to left shunt. This patient got 4 weeks of cardiac telemetry, did not show any atrial fibrillation. So patient had PFO. And in 2016, 3 trials came out in NEJM back to back showing some effectiveness of closing PFO in patient with cardioembolic stroke secondary to PFO or paradoxical embolism. So we use ROPE score, risk of paradoxical embolism, to determine whether patient stroke is from PFO or not, patent foramen ovale. And then in this patient, it was the case. So patient went for closure of PFO. So usually it is recommended in patients between 18 to 60 years of age. You have to do some workup before it is recommended. It's a team approach between neurology, stroke neurology, and cardiology. You have to do at least 4 weeks of cardiac monitoring, and it should not show any atrial fibrillation or a flutter. You have to do basic coagulopathy workup, and it has to be negative. So basically, you rule out atherosclerotic process, you rule out coagulopathy, you rule out atrial fibrillation, and then you can make the case for PFO closure. So these are the indication for PFO closure. When you don't find any other reason, you have a high degree of suspicion that this is stroke is from PFO or patent foramen ovale. When we find this and when we feel that stroke is from that, we also look for DVT on those patients. And in certain cases, in young female patients, we also look for pelvic vein thrombosis while they are hospitalized. So those are the common areas where paradoxical embolism can come from in patient with PFO. Let's see. One more slide here. This is one of the, I would say, not common reason, but we see it enough in our hospital settings. I think at St. Vincent, we see 2 to 3 patients per month of arterial dissection. So in a young patient in less than 50 year of age, without any other risk factors, we see this. So in this picture, this is the MRI showing arterial dissection. This is the carotid artery. This is cerebral angiogram showing dissection and pseudoaneurysm. And again, like this is another cerebral angiogram image showing the dissection of the carotid artery. So in most cases, the data supports use of antiplatelet agent. Before 2015, we used to treat these patients with anticoagulation, but now there are two trials which showed the effectiveness of antiplatelet therapy, and it is as good as anticoagulation. So now we treat those patients mostly with single or dual antiplatelet therapy. If we feel there is high degree of stenosis, then we use dual antiplatelet therapy. There are rare scenarios when we put these patients on anticoagulation, when there is a clot burden, when there is a mural thrombus, when we feel that there is very high degree of stenosis and there is um, impending risk of closure, then we put them on anticoagulation. And in some cases, we do angiogram while they are hospitalized and see if we need to do stenting. But in most cases, I would say 80 to 90% patients, they are treated with single or dual antiplatelet agent. We do follow-up imaging in 3 to 6 months. Most cases, if dissection is completely resolved, then we back off from the antiplatelet agent in a year or so. But if we feel that dissection flap is still there, then in some cases we have continued aspirin for lifelong or indefinitely. There are some new AI tools. I think MatPearl is embedded into our Epic. It gives you some algorithm and then which test to do before you refer the patient. So it is very helpful tool. It is just in the Epic on the top section. You can find as a Pearl, and then you can put the topic like, okay, patient has dizziness, and it can give you different scenarios and what you can do before you send the patient for referral. So it is getting popularized. I think Providence developed that tool, and they are adding more and more disease scenarios or clinical presentation scenarios. So I would highly encourage to look into that tool. I also found recently openevidence.com. So you just put what is the best treatment option for this scenario or this cases, and it gives you just like ChatGPT, it gives you most recent papers, references, and the synopsis of the treatment recommendation. So I would also encourage you to look into that. It is a very helpful, and I put bunch of stroke topics, and it gave me most up to date information on that. So so these are my takeaways when to refer the patient to us, what to look for in stroke patients. And this is our clinic information, how you can refer patient to us. We have a stroke clinic on east side and west side. And also we have a stroke clinic in Willamette Falls Hospital. So you can refer patient to us. These are my references. And thank you.